Hi, everybody. We're going to continue with the topics that fall into the category of women's health with describing something else that I have absolutely no firsthand experience with, which is physical therapy and rehabilitation around and right after pregnancy. Now, since this slideshow was originally designed by Dr. Robinson, and when I took this on from Dr. Robinson, at least at that time, she wrote very detailed PowerPoint slides. I will let you just read because I know you guys read really well. And you don't need me to read this stuff to you. So I'll let you go ahead and read as I advance this. Now, one thing that does happen, one of the things that I'd like to discuss with you is called round ligament syndrome, which perhaps you've heard of. But anatomically, the round ligament goes from the horns of the uterus up to the interior of the pelvic ring, pointed out by this white arrow here. Then it goes through a connective tissue sleeve along the pubis and eventually attaches to the mons pubis. It's innocuous when a woman is not pregnant or does not have a big heavy uterus. However, when she is in the latter stages of pregnancy, then the uterus with the fetus and the other contents can become very big and bulky, like a bowling ball inside the abdomen, and bounce around. And the tension on the round ligament can cause pain of the mons pubis. So the solution is an abdominal binder, such as you see the woman in the left lower corner wearing. Here are some more important things about changes in pregnancy. Those of you who have taken the pelvic floor elective with Dr. Curran have learned a lot about this. But for those of you who have not, we're going to review it. What you're looking at in this diagram on the right in the center is the pelvis. On top is anterior, on the bottom is the sacrum. So you're looking at the pelvis as if it's in a transverse plane section. So you can see the levator ani and the other pelvic floor muscles, which make kind of a sling at the bottom of the pelvis. The innervation is a pudendal nerve, which is and a uterine nerve, which stems from T10 through T12. These are muscles through which the cervix extends and are, as you might imagine, significantly stretched and overstretched by the process of delivery. We'll continue reviewing Dr. Robinson's very detailed notes about changes in the urinary and renal system that accompany pregnancy. Those of you who have taken Dr. Curran's elective are well familiar with this. We are also going to have a very wonderful person and dear friend, really, Crystal Warren. Some of you may have met her. She's a physical therapist with Cox and also a specialist in pelvic floor rehabilitation. She will be doing the next lecture about pelvic floor rehabilitation. We'll continue just reading Dr. Robinson's very detailed notes about the cardiovascular changes that take place during pregnancy. There is one thing that I want to discuss with you in a little bit more detail, and that is vena cava syndrome. So vena cava syndrome is partial occlusion of the vena cava as it goes toward the heart coming up from the lower body, and therefore causing swelling of the lower body. It isn't surprising that if a woman is lying supine, a large uterus with a fetus and other contents would cause that occlusion. Now, traditionally, the recommendation has to be for pregnant women in latter stages of pregnancy would be to lie on the left side, but I recently checked with recommendations of the American College of OBGYN, and they actually recommend that either side is okay to lie on as long as a very pregnant woman is not lying supine or obviously prone. The most common cardiac complication is mitral valve prolapse, and this has to do with relaxin, which we'll talk about in just a little bit. These are the respiratory changes, again, mainly from Dr. Robinson's very detailed description. What I think is important for you to understand is that the main respiratory symptom by very pregnant women has to do with respiratory alkalosis because of hyperventilation. And not surprising that as the abdomen fills up with uterus and fetus and other abdominal contents, that the breathing becomes progressively more costal than abdominal. You may have seen also that the recommendations for applying the Heimlich to a very pregnant woman who may be choking are different than it is for everybody else. Okay, so we had mentioned before relaxin, which is an endocrine hormone apparently named by somebody with absolutely no imagination. It softens the connective tissue, and of course the target of relaxin are the connective tissues and ligaments of the pelvis and the pelvic ring to allow rocking and spreading of the pelvis to enlarge and make more flexible the birth canal for a baby to get out during vaginal birth. However, because relaxin is an endocrine hormone, it actually goes throughout the whole body, and this is why you see more common mitral valve prolapse, because the ligaments holding the valve shut also become soft. In fact, this is probably the reason that pregnant women have a higher incidence of TMJ problems than women who are not pregnant. Due to factors like hormonal changes and increased blood volume, swelling of much of a pregnant woman's body is possible, certainly the feet, but other things as well. And because of the increased blood volume, areas of the body that are narrow and tight are likely to be subject to nerve root entrapment. I've seen patients, pregnant women as patients, for the problem of carpal tunnel syndrome, especially symptoms at night, on several occasions over my career. Common postural changes seen with pregnancy include forward head, rounded shoulders, and an increased lumbar lordosis. The forward head and rounded shoulders are for a couple of reasons. First, as a compensation for the increased lumbar lordosis, because you're getting more of a thoracic kyphosis, but also as a response to the increased mass of the breast tissue which accompanies pregnancy. Hyperextended knees and pronated feet are due to the softening of connective tissue. The pronated feet also responds to the increased body weight that pregnant women have. The center of gravity can shift forward, causing changes in balance. However, we're going to talk about in the next slide some research that shows that women have an anatomical adaptation in the lumbar spine that helps to moderate this. And the muscular changes, kind of as shown in the model over in the picture on the left, shortened hip flexors because of the anterior pelvic tilt, tight lower back musculature because of lumbar lordosis, tight pectorals, again for the reasons that we described, and then overstretching of the abdominal muscles, the lower cervical and upper back muscles. And as we described a little bit before, the pelvic floor muscles can be subject to strain because of the increased mass of the abdominal content. Here is the research article that I was describing before. Here are the authors, and I've included the abstract, but I'll try to describe a little bit what's going on. What these evolutionary biologists have found is that women, compared to men, have lumbar vertebrae which are more wedge-shaped, such that they're longer anteriorly and shorter posteriorly. This allows an adaptation in pregnancy such that women can get their center of mass backwards. So in the illustration that's all the way to the right, here is a woman with this adaptation allowing them to pivot rather in, in the lumbar area rather than having a lumbar area that is more straight, such as you'd see in a non-pregnant woman, which is the illustration all the way to the left. This pivoting in the sagittal plane allows for postural adjustment rather than depending upon constant tension being generated by the lumbar extensors, and therefore way less muscular fatigue and less of a chronic joint compression due to that chronic active muscle tension to remain upright. Increased levels of progesterone can cause decreased motility of the organs of the GI system, and those can cause decreased appetite, nausea and vomiting, which are part of morning sickness, which perhaps you've heard about or experienced if you've been pregnant yourself, or higher incidence of gallstones. Now, there's three main things which, as physical therapists, you can help patients with. And first one that we're going to talk about is diastasis recti, which is a split between the rectus abdominis, which is very, very common. We'll talk about how common it is. Posture and strengthening, both pre and postpartum. We talked a little bit earlier about some of the muscle tightnesses and some of the stretch-induced weaknesses that you tend to see with pregnancy and accompanying postural changes, and then pelvic floor rehabilitation. So those of you who took the pelvic floor elective with Dr. Curran have learned a lot about that, and those who have not are going to learn some of it with Crystal Warren a little later next week. Diastasis recti, as I said, is a split between the muscles of the muscle bellies of the rectus abdominis. And it's defined by at least 2 centimeters between those muscle bellies, measured right above and below the umbilicus. Most commonly, it's because of either parity, which is the medical word for pregnancy, or because of abdominal surgery. Although it is very common in pregnancy, according to some literature, almost 100% of pregnant women will have it. And in a large minority, that deformity of this, at least some split between the rectus abdominis, is permanent. This diagram shows a representation of a gigantic rectus abdominis and surgical repair, although somebody with an abdomen as fit as shown in this drawing would probably not have a rectus abdominis, especially not this big. The potential consequences due to rectus abdominis include problems with fetal positioning, that is, that part of the fetus is actually sticking out of the abdomen, whereas the skin is still there and the uterus is still there, but the abdominal muscles are not influencing or not constraining the fetus within the abdomen. Ineffective abdominal contractions during or after pregnancy, back pain and postural problems because of the weakness of the abdominal wall, and problems with activities that require the generation of high intra-abdominal pressure. The at-risk population includes anyone, male or female, with sustained high pressure on the abdominal wall, but pregnancy is probably the most common reason for this high sustained pressure. This describes a study that was published in the JOSPT a few years ago regarding the effects of rectus abdominis on muscular performance. I'm not going to read it to you, but I'm going to describe what some of the points say. What this study did was it was a longitudinal study comparing women 7 weeks after delivery to the same women 6 months postpartum. And it found that generally both the interecti distance with women, postpartum women who have had rectus abdominis, improved between 6 weeks and 7 months. However, for the women, and this is the point, the second bullet point, for the women who had a rectus abdominis that did not improve significantly, the consequences on their abdominal muscle performance was greater than for the women whose rectus abdominis did improve and did shrink. And not surprisingly, there was a very significant difference between women who had had a child, given birth to a child, and women who had never given birth to a child in abdominal muscle performance. This is a study that compared the effect of strengthening, emphasizing abdominal control in preventing diastasis recti. What the researchers did in this study was they had a control group of 10 women, 10 pregnant women who did not do the exercise program, and 8 pregnant women doing the exercise program. They found that 9 out of 10 of the women from the control group had diastasis recti with a mean interectus distance of almost 4 centimeters. Only one woman of the exercising group had diastasis recti, and she had a much smaller mean interectus distance of not quite 1 centimeter. The exercises that they did, as you might imagine, they couldn't do crunches or leg lifts or things that really involved a lot of trunk flexion, but they did upper and lower extremity resistance exercise while emphasizing abdominal control, a lot like the dead bug type of exercises, which you guys are probably familiar with. Here are some recommendations for interventions that could be done to help diastasis recti after birth. First of all, the woman on the yellow mat here doing the abdominal exercises is doing a curl up, and she's using a towel or a sheet to help pull the bellies or hold the bellies of the rectus abdominis from separating while she does these exercises. Another intervention that can help is an abdominal binder, such as you see in the picture to the left. Another physical therapy intervention that can be considered is pain control during labor and delivery, especially TENS. Of course, you need to watch out for electrode placement, place them paraspinally or perhaps on the upper sacrum, watching out for suprapubic locations, because suprapubic locations of putting on electrodes may interfere with fetal monitors. There was a study that showed that TENS after cesarean birth, when used for pain control, helped to decrease pain, nausea, and vomiting, and led to sooner ambulation and greater alertness in the infant and less depression in the mother, probably because of the decreased use of narcotics for pain. One of the things that we want to help with pregnant women for pulmonary management is teaching them abdominal breathing as much as possible, and also showing them huffing, which looks like this, rather than coughing to clear the lungs, because there's less stress on the pelvic floor that way and less likelihood of incontinence. Now, if you remember the song Moves Like Jagger, this is Jagger, and these are his moves. It sounds a little not as good as I think the song makes it out as. Now, helping with posture is something that we can help with physical therapists. So, for example, here we have a picture of a woman breastfeeding a baby, and she's using this cushion, which is called a boppy. When my kids were small, we had these as well. And this is used really nicely, you see, because one of the complaints that I at least have heard from women who are breastfeeding is they feel like a crab because they're always bent over a baby and holding up all the weight of the baby as they're breastfeeding. But what this allows the woman to do is have the baby really resting on her lap through the pillow and maintain an upright posture while not holding all the weight of the baby in her arms. Strengthening is really important for recovery after birth, and here we see both a picture and a description of some of the exercises that might be helpful for women shortly after giving birth. So there's several changes that women can anticipate during pregnancy and after delivery, and several things that we physical therapists can help them with, such as we see here.